There is a conversation that happens in surgical waiting rooms that almost never happens in the surgical consultation that preceded it, and it is the conversation between a family that has just watched someone they love deteriorate significantly after an operation that was presented to them as routine, and the quiet understanding that the surgeon knew the risk was high and communicated it, but that the words used did not fully convey what high risk looks like when it arrives in the form of a person who walked in for an operation and came out diminished in ways that do not fully reverse. I am not here today to frighten you away from surgery. Surgery saves lives at every age, and many of the operations I am going to discuss have outcomes that are excellent in the right patient at the right time. What I am here to discuss is the specific dimension of surgical risk that becomes dramatically more significant in adults over 60 with certain characteristics, and that is systematically underweighted in how surgical decisions are presented and made. That dimension is frailty, and the question it asks is not simply whether you can survive the operation, but whether the body that emerges from it has enough reserve to recover to a meaningful functional life on the other side. Before anything else, what I share in this video is educational information only. It is not medical advice. The decision to proceed with or decline any surgery should be made in direct conversation with your surgical team, your anesthesiologist, and ideally a geriatrician or frailty specialist who can provide a complete assessment of your reserve capacity. What I want to give you today is the framework for having that conversation with the specific questions that lead to the most informed decision. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. The surgical risk picture for this age group is one of the most important and most inadequately communicated areas of medicine, and the 4 questions I will give you at the end of this video are the ones I wish every family had before the consent form was signed. Subscribe to this channel now because every week I bring you specific, grounded information about what your body needs after 60, and this video addresses the most consequential medical decisions this age group faces. The frailty framework is the essential context for everything I am going to describe. Frailty is not a synonym for old age. It is a specific syndrome of reduced physiological reserve across multiple organ systems that makes the body less able to respond to and recover from physiological stressors, including the stressor of major surgery. A fit, active 75-year-old may have the surgical reserve of a 55-year-old. A sedentary, diabetic, sarcopenic 65-year-old may have the reserve of someone 20 years older. The frailty phenotype described by Fried and colleagues in the Johns Hopkins Aging Research includes 5 components: unintentional weight loss, exhaustion, weak grip strength, slow walking speed, and low physical activity. The presence of 3 or more of these defines frailty, and multiple large surgical outcome studies have found that frailty is a stronger predictor of postoperative mortality and major complications than either age or the primary diagnosis requiring surgery. Why does frailty predict surgical outcomes so strongly? Because surgery is a massive physiological stressor. Major operations require the cardiovascular system to manage the fluid shifts of anesthesia and surgical blood loss. The immune system must manage the infection risk of an open wound and a period of immunosuppression. The respiratory system must clear the atelectasis of anesthesia and immobility. The musculoskeletal system must begin recovering from the catabolic effects of surgery that break down muscle at a rate of 1 to 2% per day during bed rest. And the brain must manage the neuroinflammation of major surgery that, in frail adults with reduced cognitive reserve, can produce postoperative delirium and the postoperative cognitive dysfunction that in some cases does not fully resolve. A body with adequate reserve handles all of these simultaneously and recovers. A frail body cannot meet the simultaneous demand and begins a cascade of complications that, once started, are difficult to reverse. Type in the comments right now whether your surgical team has ever used the word frailty or performed a formal frailty assessment before discussing a surgical option with you, because the frequency of that assessment in those comments will tell me something important about how consistently this evaluation is being performed. The first high-risk surgery category is open heart surgery in adults with significant frailty, and the specific scenario most relevant today is the question of aortic valve replacement for severe aortic stenosis. Severe aortic stenosis, the narrowing of the aortic valve that restricts blood flow out of the heart, is increasingly common in adults over 75 and was historically treated with open surgical aortic valve replacement, stopping the heart, going on cardiopulmonary bypass, cutting out the diseased valve and sewing in a new one. In fit, lower-risk patients, this operation has excellent outcomes and produces substantial improvements in quality of life and longevity. In frail patients, the open surgical approach carries dramatically higher rates of mortality, stroke, prolonged intensive care stays, and failure to recover to baseline function. The emergence of transcatheter aortic valve implantation, TAVI, which delivers a new valve through a catheter in the femoral artery without opening the chest, has transformed the risk calculation for these patients. Multiple randomized trials have demonstrated that TAVI produces equivalent or superior outcomes to surgical valve replacement in high-risk and intermediate-risk patients, and current guidelines support TAVI as the preferred approach in patients over 75, regardless of surgical risk. The critical point is that the existence of a less invasive alternative does not eliminate the need for the frailty conversation. TAVI in severely frail patients still carries significant risk of poor functional recovery, and the question of whether any valve intervention in a severely frail patient extends meaningful life is one that requires the full picture of the patient's functional status, the trajectory of their frailty, and their values about the trade-offs of intervention versus comfort-focused care. If you or a family member is facing this decision, the specific questions to ask are, what is my surgical risk score and my frailty classification? Is TAVI a viable alternative to open surgery in my case? And what does the realistic functional outcome look like at 6 and 12 months for a patient with my specific frailty profile? The second high-risk surgery category is aggressive spinal surgery in older adults with chronic back pain, and specifically, the large multi-level spinal fusion procedures that have proliferated in the older adult population over the past 2 decades. Spinal fusion surgery, in which adjacent vertebrae are permanently joined to eliminate movement at a painful or unstable spinal segment, can produce excellent outcomes in well-selected patients with specific and clearly defined surgical targets: a documented instability, a nerve compression with correlating symptoms, or a deformity producing measurable functional impairment. The problem is that chronic back pain in adults over 60 is often multifactorial, involving facet joint arthritis, muscle deconditioning, psychological pain sensitization, and disc degeneration at multiple levels simultaneously, none of which is fully addressed by surgical fusion. Large studies of lumbar spine surgery outcomes have consistently found that results are strongly correlated with the psychological and social health of the patient alongside the structural findings on imaging. Adults with high levels of catastrophizing, depression, or poor social support have substantially worse outcomes from spinal surgery than those without these factors, regardless of the surgical indication. And in frail older adults undergoing multi-level fusion, the operative duration and blood loss, the postoperative pain management challenges, and the rehabilitation demands of a major spinal reconstruction produce a complication rate and a functional recovery trajectory that frequently falls short of the preoperative expectations. The prehabilitation concept is particularly relevant here. Adults who spend 6 to 12 weeks before major spinal surgery, specifically strengthening the core and lower limb muscles, optimizing their nutrition for surgical healing, and addressing any modifiable risk factors, including blood sugar management and smoking cessation, consistently show better surgical outcomes than those who proceed directly from diagnosis to operation without this preparation period. And share this video right now with one person in your life who is being offered spinal surgery and who has not yet had a specific, honest conversation about the realistic expected outcomes at 1 year for a patient with their frailty profile and their psychological pain characteristics. That conversation may be the most important one before the consent form. And if you are not yet subscribed to this channel, tap that button now and ring the bell. The third high-risk category is major cancer resections, and I want to focus specifically on the pancreatic Whipple procedure, one of the most technically demanding and physiologically demanding operations in abdominal surgery, as the representative example. The Whipple procedure, or pancreaticoduodenectomy, removes the head of the pancreas, the duodenum, part of the bile duct, and the gallbladder, and reconstructs the digestive tract with multiple intestinal anastomoses. In high-volume centers with experienced surgeons, the operative mortality is now below 3%, a dramatic improvement from historical rates. But post-operative morbidity remains high. Pancreatic fistula, delayed gastric emptying, wound infection, bile leak, and the metabolic consequences of reduced pancreatic function affect 40 to 60% of patients in the postoperative period, extending the hospital stay and the recovery period substantially. In frail patients over 75 with pancreatic cancer, the specific question that must be asked before recommending a Whipple procedure is whether the cancer's biology, specifically its resectability and its likely response to treatment, combined with the patient's functional reserve, means that surgery produces a meaningful survival benefit and quality of life in the time remaining. For cancers with favorable biology in fit patients, the answer is often yes. For borderline resectable cancers in frail patients with limited life expectancy from other causes, the conversation may need to honestly include whether an operation that has a 40 to 60% rate of significant complications serves the patient's goals better than non-operative treatment that preserves their functional status for the time they have. This is one of the most difficult conversations in surgery, and it is one that requires the patient and family to participate with a clear understanding of their values, whether the priority is maximum time at any functional level or maximum quality of functional time. Both are legitimate values, and they may lead to different decisions. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell. I want to describe a scenario that illustrates the fourth category, elective joint replacement surgery in a medically fragile older adult. Consider an adult of 72 who has severe knee osteoarthritis producing significant pain and mobility limitation. She has type 2 diabetes with HbA1c of 8.2, peripheral vascular disease with impaired circulation to the lower limbs, and a BMI of 38. Her grip strength is reduced. She walks slowly. She has had 2 episodes of postoperative wound complications from previous minor procedures. Total knee replacement in this specific patient carries dramatically elevated risks compared to the same procedure in a metabolically healthy, active 72-year-old. The elevated HbA1c significantly increases wound infection and prosthetic joint infection risk. The peripheral vascular disease reduces the tissue perfusion to the surgical site required for healing, and the obesity increases the mechanical stress on the new prosthesis and impairs the rehabilitation response that produces the functional improvement the operation was intended to deliver. The appropriate response to this scenario is not automatic refusal of surgery, but a structured prehabilitation program, optimizing blood glucose to an HbA1c below 7.5 before proceeding, addressing the vascular disease with appropriate medical management, targeting a realistic weight reduction goal, and initiating an exercise program that builds quadriceps strength and improves cardiovascular reserve before the operation. This preoperative optimization may itself produce sufficient symptom improvement that surgery can be deferred or replaced, and if surgery is ultimately pursued, it produces a patient whose surgical risk has been materially reduced. The question that identifies whether this conversation has occurred is, has anyone assessed my surgical risk and given me specific, time-defined targets for modifiable risk factors before agreeing to proceed? The fifth category is emergency abdominal surgery, which is specifically included not because elective surgery should be avoided, but because the consequences of allowing certain conditions to deteriorate to the point of emergency surgery are consistently more severe than the risks of earlier elective intervention. Emergency surgery in adults over 65 carries mortality rates 5 to 10 times higher than equivalent elective surgery for multiple reasons. The physiological derangement of the acute illness has already stressed the cardiovascular and renal systems before the anesthetic begins. The surgical field is contaminated or compromised by the emergency condition, and the absence of preoperative optimization means all the modifiable risk factors are unaddressed. Emergency abdominal surgery for perforated diverticular disease, for example, carries a mortality of 20 to 30% in the over 70 population, compared to below 1% for elective sigmoid colectomy performed before perforation in a prepared patient. The conditions most commonly producing emergency abdominal surgery in older adults that could have been managed electively include symptomatic gallstone disease presenting as cholecystitis or cholangitis, complicated diverticular disease presenting as perforation, and large bowel obstruction from a colorectal cancer that was present for months before it obstructed. Each of these represents a situation in which earlier evaluation and earlier elective intervention would have produced substantially better outcomes. The message is not that emergency surgery should be avoided. It is that the conditions most likely to produce emergency surgery in older adults are conditions whose warning symptoms, when brought to medical attention earlier, allow an elective approach with dramatically better risk profiles. Here are the 4 questions every older adult and every family should ask before agreeing to surgery. First, what is my frailty score or frailty classification, and how does it affect my predicted outcome from this specific operation? A surgical team that cannot answer this question specifically has not performed the assessment most relevant to the decision. Second, what are the realistic functional outcomes for a patient with my profile at 6 months and 12 months after surgery? Not the best case outcome and not the complication rate alone, but the realistic expected functional trajectory for someone with my specific characteristics. Third, are there less invasive alternatives and have they been specifically considered and explained in my case? TAVI for aortic valve disease, endoscopic approaches for some bowel conditions, and radiological interventions for some vascular conditions are examples of alternatives that may carry substantially lower risk profiles for frail patients. Fourth, if I proceeded with a prehabilitation program for 6 to 12 weeks before surgery, would my surgical risk change, and would my expected outcomes improve? The answer to this question frequently reveals both modifiable risk factors and the feasibility of a preparation period that improves the surgical risk profile substantially. 4 things to carry away. First, frailty, not age, is the most important predictor of surgical outcomes in adults over 60. A formal frailty assessment is a reasonable and important request before any major elective surgery, and should include grip strength, gait speed, and an assessment of energy, activity level, and unintentional weight loss. Second, for several of the highest risk surgical categories, less invasive alternatives exist that carry significantly lower risk profiles in frail patients. TAVI for aortic valve disease is the most established example. Asking specifically whether a less invasive approach has been considered is always appropriate. Third, prehabilitation, the structured optimization of physical fitness, nutritional status, and modifiable medical risk factors before surgery, consistently improves outcomes for adults undergoing major procedures and reduces the operative risk for those who ultimately proceed. 6 to 12 weeks of targeted preparation is not delay. It is risk reduction. Fourth, the question that most changes the decision-making conversation is not whether the operation can be done, but whether the realistic functional outcome for a patient with this frailty profile represents a meaningful improvement in quality of life relative to the risks of the procedure. That question requires honest engagement with both the surgical team and the patient's own values about the trade-offs of intervention versus the functional status currently available. Surgery is not a verdict. It is a decision that belongs to the patient and to the family, made with full information about what the realistic outcomes look like for a body with the specific reserve capacity available. The information in this video is intended to support that decision, with the framing that most consistently produces the outcome the patient and family actually want. Share this video with one family facing a major surgical decision for an older relative, because the 4 questions I have described may be the ones that change how that decision is approached. And subscribe to this channel, because every week I come here with one purpose: to give you the specific information that makes the most consequential decisions genuinely informed. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.